Hello, my name is Dr. Surya Swaminathan. I'm a nephrologist and a renal transplant physician. In this talk, I'm going to explain the basics of thrombotic microangiopathy and hemolytic uremic syndrome and how this syndrome affects the kidneys. TMA or thrombotic microangiopathy is a histological diagnosis. It consists of endothelial injury, aggregation of platelets to the endothelium, and damage to the red blood cells, which leads to microthrombi in the arterioles and capillaries. If you look at the figure on your left-hand side top, that shows a normal blood vessel with normal endothelium. The flow is happening in the middle with the red blood cells flowing through the middle and the platelets flowing along the sides with plasma. On your right hand side top, you can see a damaged endothelium. Because the endothelium is damaged, now the platelets start adhering to the sides of endothelium and the red blood cells, as you can see, are distorted or damaged. These damaged red blood cells are called schistocytes. In the top left hand bottom, you can see the blood film. The arrows, solid arrows, point towards the damaged red blood cells, and the dotted arrows are pointing towards platelet aggregates. Now, in the bottom right-hand side is a histology of a kidney and a glomerulus. As you are aware, the glomerulus is full of capillaries. The black arrows here are pointing towards the microthrombi within the glomerulus. Because of the endothelial injury, there is microthrombi, and if the glomerulus are full of microthrombi, then there is organ dysfunction or acute kidney injury. When TMA is a histological diagnosis, HUS or hemolytic uremic syndrome is a clinical syndrome which signifies microangiopathic hemolytic anemia, thrombocytopenia, schistocytes or the damaged RBCs, and there is organ dysfunction, for example, acute kidney injury. I told you TMA is a histological diagnosis, which means you need a tissue biopsy. But even before you proceed that, the thing that is obvious to us is blood work. So what will the biochemistry look like? What are the pointers that will help us think about TMA or hemolysis in a particular patient? So when you look at the blood work, you will find features of hemolytic anemia. So what are the features of hemolytic anemia? It is anemia, which is low hemoglobin, and you want to know that there is damage of red blood cells, which is otherwise called hemolysis. So the features in the blood test will be high bilirubin, high reticulocyte count, high LDH count, and low haptoglobins. These are the features of hemolysis. Sometimes if the hemolysis is very severe, you can even have hematuria or hemoglobinuria in urine analysis. The other features of thrombotic microangiopathy is low platelets, and you will see damaged red blood cells in the film as we saw in the last slides. Because of the microangiopathy, and kidneys seem to be the most commonly affected organs, then you also see signs of acute kidney failure, which is rise in urea and creatinine. One of the things as clinicians we need to be aware of is the distinction between TTP, which is thrombotic thrombocytopenic purpura, and HUS, which is hemolytic uremic syndrome. Both of them have low platelets, and both of them have got thrombotic microangiopathies. But TTP is predominantly a hematological disorder affecting the platelets. Hematologists are more interested in that, whereas HUS is where renal physicians are involved and are interested in. One of the key differentiating tests that we can see in blood work is Adams TS13 level, which is very low in the case of TTP. Normal levels actually rule out TTP, and we are able to come to the diagnosis of HUS, something of interest and that we can keep in mind. So, how does TMA /HUS affect the kidneys, and how do we diagnose this? As we said before, TMA is a histological diagnosis, but before we go there, we need the blood work as discussed in the previous slides. We also need a kidney biopsy to look for TMA. Irrespective of what caused the TMA, the biopsy will look the same. We'll have clinical evidence of acute renal failure with rising creatinine and urea, and sometimes it is so accelerated that you would get acute renal failure and anuric renal failure. So what are all the common causes, etiology for TMA HUS in the kidneys? The most common cause is Shiga toxin, which is E. coli induced diarrhea. This is much more common in children. So that's why in history we always ask about diarrhea, and if someone presents with diarrhea, acute renal failure, that could be secondary to volume depletion, but we also look at the rest of the blood work to see if there is any associated low platelets or low hemoglobin. That will then lead us to think about HUS and order further testing. I've said this again and again, the primary pathology is endothelial damage. So any etiology that can cause severe endothelial damage, such as malignant hypertension, sepsis, lupus, antiphospholipid syndrome, they all can present with the clinical syndrome of TMA and HUS in the kidneys. We're also very interested of late about the complement-mediated pathway. Most common is complement factor H and I deficiency, which causes complement activation and triggers TMA in the kidneys. So in this case, we order genetic testing, and if that is proven, then eculizumab in the last few years has been available for treatment. TMA in the transplanted kidney is very interesting, even more interesting than TMA in the native kidney. So there are two types of TMA that can affect the transplant kidney. One is the recurrent TMA. So initial diagnosis is TMA that led to kidney failure, and then the patient was assessed, suitable for transplant, got a transplant, and the primary pathology recurred. So that is recurrent TMA. TMA can also occur de novo, that is new occurrence of TMA after the kidney transplant. Again, the basic principle is just the same. Anything that causes endothelial injury can cause TMA in the transplant kidney. For example, severe vascular rejection is can cause TMA. Before we diagnose TMA/HUS or atypical HUS, we have to exclude infections. There are several medications that we use in the post-transplant setting can all cause TMA. For example, ATG, the CNIs, tacrolimus, cyclosporin, the mTOR inhibitors, sirolimus, they all can cause TMA in the transplant kidney. Treatment of HUS TTP is a talk on its own. But on the most basic level, what we want to do, we have to treat the cause. For example, if it is a E. coli Shiga toxin, then we treat the infection. If it is high blood pressure, malignant hypertension, we treat the high blood pressure and medical hypertension to bring the blood pressure down. If it is genetic, I've already discussed that we can use eculizumab to turn off the complement activation. And another important distinction to distinguish between TTP, which is a primary hematological disorder, versus HUS. In TTP, we can do plasma exchange. So that was a very brief summary or introduction about TMA, TTP, and HUS and how it affects the kidney. We will discuss in person about a recent case in a young patient who presented with TMA 2 months after receiving a kidney transplant and how we treated her. I look forward to more face-to-face case-based discussions with you all, and once the discussion is over, I'll upload the key features of that case in this channel. Thanks for listening.